Well, today's session's title, Leading on a Burning Platform with No Fire Hydrant, sounds a little bit intimidating. This is no doubt something that many of us have encountered over the past year. We asked Dr. Chris to present on leading in a crisis situation while not allowing the learning environment to fall by the wayside. And Dr. Chris is the ideal person to present on this topic in her roles as Vice President of Medical Staff Affairs for Carilion Clinic and Associate Dean for Clinical Sciences for Virginia Tech Carilion School of Medicine. Dr. Chris would prefer we hold questions until the end just because of the timing of things. And if you don't mind just typing them in the chat box, I will convey them when she concludes. And one final note before we get started, please be sure to let us know you attended this session. There are two main ways you can do this. You can complete the form for CME and or faculty development related to teaching, the link to which Sandy has and will again post in the chat. And at the very least, please make sure that your Zoom name reflects who you are. If your name is currently your phone number, your spouse's name, your third grader's name, generic iPhone, or anything else that will not allow us to identify you, you can easily change this in the participant list by clicking, I think it says more, and then selecting rename. So I think we all should be looking forward to this conversation regardless of our roles. So please join me in virtually welcoming Dr. Tracy Chris.
Well, thanks a lot, Sherry, Dr. Wicker, and I want to say thank you to the Teach Academy for inviting me to make this presentation. And also, right up front, I'd like to thank Elvira Bierbick and Brian Brindle on the tech side, as well as Sandy DeHart this morning for helping this to get going this afternoon. So as Sherry said, leading on a burning platform with no fire hydrant. And we have quite the story to tell. I want to go over the learning objectives, and they're really things to look at. Describe 4 principles when leading in a difficult situation. Identify the most important thing to do in a crisis, and we certainly have learned that. Identify the players who are going to be working with you in terms of collaborative decision making, and collaboration is going to be something that I'm going to talk about a lot today. And recognize the importance of benchmarking, and then recognize the value of temperament or demeanor during a crisis. So leadership when it's tough. I took these principles from a book called Unconventional Leadership, written by Nancy Schlichting. And Nancy Schlichting was the CEO at Henry Ford Health System when Henry Ford and the city of Detroit were emerging from financial crisis and a really difficult situation. And so these are 4 principles that she talks about. And I found them to be very important during this time, and still important as this is an ongoing event. Being a student of leadership, learning what you can, getting out of your comfort zone. They're going to be really uncomfortable decisions to make, and you may have to make them without evidence. Surround yourself with supporters. Work with people who are helpful. Work with people who have the same goals as you, who want to get to the same place. And then keep your eyes on values. And you're going to hear me talk about this a lot today, because we really kept our eye on several things and that were of significant value to us and to the students. So keep your eyes on values. So these 4 principles are things that we really went by and continue to go by today, as this now has become a chronic crisis. So the AAMC talks about the learning environment as playing a key role with students. And medical education is dependent upon an inclusive curriculum and an environment designated to promote student learning and maturation. And so indeed, we have to make sure that we have a learning environment that's conducive to student learning and is student focused. We talk about patient-centered care, and the learning environment is student focused. So, hey, March 17, 2020, we don't have one. We got not much, okay? We don't have a learning environment. We have each other, and that's a lot. We don't have a learning environment. We don't have a place to have our students to go to learn, at least in the hospital setting. So we got nothing, as people will say. The platform began to burn, and we didn't really have a fire hydrant. None of us had ever been through something quite like this. I mean, there was the Ebola crisis, and those of us on the call may remember the HIV crisis, and we hadn't been through something like this where we really didn't have a hospital in which to teach patients, because COVID was a significant issue and continues to be. So the platform began to burn, and we didn't have a fire hydrant. So here was the platform. We had just finished week 4 of the 6-week clerkships, and we were in the middle of rotation 6. So there are 8 clerkships in the 3rd year to get through the curriculum here at BTC SOM. So we were in week 5 of clerkship 6. So we had significant ways to go. We had 14 weeks left in year 3, and that's a pretty good percentage of the time. That's over 25%. So we had a lot of the year left. As far as the M4s, at that time, we were in a curriculum just like we're in right now. This morning, I've been precepting in Transition to Residency 1. And we were in that same curriculum at this time last year when COVID emerged. The match was that Friday. How do you have a match when you can't have people in the room together? EPAs, or entrustable professional activities, were being completed and assessed. And research day was coming up, where a couple hundred people come together in order to attend the research symposium. So what do we do? There was no fire hydrant. We hadn't been through this before. We needed to educate students. What do we do? What's our guidance? And who can we ask? So these were all questions that we faced that week. I come back to number 4 on that list. Keep your eyes on values. And our compass was that the quality of education must be maintained, followed by there must be a workforce to care for patients July 1, 2020. And I want to emphasize, whenever we communicated with the students, we emphasized point 1. We wanted the students to be clear that the quality of their education was number 1 in our minds. And then we also knew that number 2 was important as well. Important for hospitals and important for patients. And I'll say several times, and this was pounded into my head while this was all going on, we must meet the learning objectives, either by inpatient care, simulation, online cases, readings. We had to focus in on our learning objectives for clerkships and electives, and we couldn't let that go. Well, communication is important always, and it was especially important during this time. And again, from learning from others, there are 5 main points that we need to be focused in on. Address vulnerabilities due to the lack of in-person communication. You really lose something. I mean, today I'm speaking on a Zoom presentation. This is wonderful. I miss seeing people's eyes, looking at them as we're communicating. So there's something about communicating with people in person. Attend to emergency communication weaknesses. How do we communicate with people? Never assume that an emergency communication is received. It may or may not be. Prepare for before, during, and after the emergency. I mean, we had to handle the emergency. What are we going to do? And then what are we going to do afterwards? And then don't overlook the value of staff support in communication. So I read Becker's on a regular basis, Becker's Hospital Review, and I read a lot. And I found this quote from Hans Vestberg, from the CEO of Verizon. And you can read it there. He talks about transparency and communication. And he said, throughout the pandemic, Verizon has hosted a daily live webcast for employees to ask questions and stay connected. And I was impressed a large company like this would do something like this. During this time, I also talked with my own mentor in a fellowship I completed, Dr. Jennifer Daly, and I said, I feel like I'm communicating on the hospital side, in the school side, I'm communicating things over and over, and I feel like I'm wearing people out. And she said, when you feel like you've gotten to the point where you've worn them out, that's probably the time where you've communicated whatever you're communicating just enough. So I felt a little bit relieved by that. And I've kind of gone by that principle the whole time. So back to the platform. We had to get our M3s through each of these clerkships. And the key component, if you remember nothing else from this presentation, is must meet the learning objectives. Our clerkship directors were asked to quickly put a plan together, and resources for them included these things that could help create a very positive learning environment. Specialty specific recommendations from each of their societies. And again, things were evolving, right? It wasn't like it was all sitting there ready to go. Grand rounds here, online cases, Carillion virtual lectures, and online simulations. An example of that would be Dr. Mark Watts from Family Medicine actually gave out pig's feet through the Sim Center, and he was able to conduct some of his simulations online with the students. So people were becoming creative, maybe as creative as they've ever been, but we started to put together ideas. And how did the students react to this? They were wonderful. They were wonderful. This was disruptive to them. It was disruptive to their education. Are we going to graduate? What's going to happen? They were wonderful. And I listed some keywords that came to my mind as I put this presentation together. They were patient and kind and resilient, but they also were tentative and scared, but they were understanding. They felt some of the same things we did, and we communicated to the students that, we're finding our path as well. We're finding a way through this, and we're all doing this together, and we're all in this together, and we're working with you in order to find our way through this. So we try to let them know, hey, we're all human in this, but we're all in this together, and we're all going to work on this together. So what do we do? Well, the M3s completed rotation 6 and did some online work and took their exams virtually. And then they started rotation 7 in what we call 4+2 model. Well, what does that really mean? How are you going to do any clinical work, and how are we going to make this up? So those were all questions on the table. So in this 4+2 model, our clerkship directors put together 4 weeks of online work where they could study and learn and prepare for exams. And then 2 weeks, we put together a situation where they would either take an elective or do more research time. And an elective would be online and research. And we quickly put together a lot of online electives. And so we put together this 4+2 model. And I want to say, if you're in the hospital or you're at the school and you see any of these people that I have listed here on this list, please say thank you to them. They really responded quickly, without hesitation, and put together curriculum for our students so that this year could continue to move forward. And they were wonderful, and they're still wonderful. And I like to say that I think we have the best clerkship directors in the country. And I like to talk about them. And again, please be sure to say thank you to any of these people that you see. And our Dr. Schmidley here for neurology actually won an award through the American Association of Neurology as the best teacher in the nation this past year. So thank you to all of these people. So the plans vary by clerkship. Our neurology students took an elective and filled in that time because it's a 2-week rotation. Radiology became all virtual, so we were able to continue in that rotation. Our core clerkships, as I said, went online for 4 weeks, and then we had to figure out, could we do some telemedicine? Could we make up some clinical time? Could we do some of that? Because what was going to happen was, as we went back into the clinical rotations, whenever, we weren't sure when, the time had to be made up. We couldn't have people complete a clerkship and never see a patient. So we were going to do 4 weeks of clinical work. And the more that we could do through telemedicine in year 3, the less time we would have to make up in year 4. because remember, we hope to have another year 3 class coming into the hospital as well. So in rotation 7, psych and OB were able to put together telemedicine for our students, and that really helped us once. It really helped them to stay engaged and helped them to have less time this current year to make up. So we had a rapid development of electives, as I mentioned, mostly virtual. Some were not. Some were able to work together inside, and I'll go into that in a minute. 11 electives were developed of excellent quality, and our faculty was phenomenal. And here's what that looked like. We had basic dermatology, which was led by one of our alumni, and that was Dr. Josh Eichenberg. And the COVID-19 pandemic elective, which was led by Dr. Sloopner, Very, and Skolnick, as busy as they were. And history of medicine, Dr. Hugh Kraft, hospital infection control, pandemic response. That was Dr. Bafubani. And there's some publications coming out of that elective in which he worked with a 4th-year medical student. Wilderness medicine education from Dr. LaRue in emergency medicine. Advanced anatomy prosection with Dr. Carol Gilbert, and then research. Or they could study for step 2. Now, what I hope you've taken home from this slide, and we'll talk more about this as we talk more, is everybody stepped up to the plate. You heard me say EM, IM, PEDS, surgery, Dr. Gilbert. People were stepping up to the plate, and that's something to be learned from this slide, the collaborative effort. We made a mistake in our communication, though, as we place students in electives, and I will say I own this mistake. I've apologized to the students, and I learned from this. We placed in a rush to kind of do some things because time was moving along, and we had to have them have credited electives. At one point, we placed them all in one elective, and the students pushed back, and good for them. They let us know that they didn't like that. They didn't all want to take that elective. And I take the blame for missing the boat on communication. And we got better in that area. And I'll tell you how we got better. But that was a mistake that we made. Dr. Very led the establishment of the COVID-19 task force. And we had representatives on this from each class. And we began to meet weekly. And we still meet. This allowed us time to seek input from the students and to hear their thoughts on what was going on, to hear their fears, to hear their concerns, and to get input on how we could move forward. And it's been a very valuable addition to what we were doing at that time, and has been up and running now for months, probably 8 to 10 months. So back to our M4s, what was going to happen with them, because they were in the middle of this TTR1 program. Well, we moved our EPAs to a virtual format, and some were already virtual, and we canceled EPA number 12, which was doing an IV. I'll point out that today we tested them and assessed them on EPA number 12, and we were able to do that in person at the SIM Center on their ability to do a procedure. But most of our EPAs moved to an online format, and we had some success with that, and it seemed to go pretty well. Probably not ideal, but it worked okay for us. We had the match as well, and there's Dean Lehrman and Dr. Knight, and we had a virtual match, and our match went very, very well, and they led the way on that. Collaboration at its finest, and I'm going to circle back to the online virtual EPAs. So we had a day, I had, not to talk about me, but I had been in New York City and at 3 Broadway shows just until 4 Broadway shows until March 8th, just when on March 11th, the world kind of blew up with COVID. And so about 14 days into what we were doing, I developed severe chills, and I was supposed to oversee an EPA delivery that morning. And I had to then be quarantined for 2 weeks. Remember, back then we weren't testing everyone in the same way that we are now. And so I was quarantined, but able to, with collaboration of IT and Drs. Fogel and Dr. Watts and Dr. Karp, participate from home. And we were able to do online virtual EPAs. And they stepped up to the plate with about 10 minutes notice. And I'm not kidding about that. It was about 10 minutes notice. And they ran that themselves and did a great job. We get into the idea of, as our M4s move along, what are we going to do? Because not all of them had completed ICU over at the hospital. And ICU is a requirement for our students to be able to graduate. So what we learned from that was we began to query the 7 students who had not completed an ICU rotation in that M4 year. And we learned something, that on their clerkships and in electives, they spend, we don't know where they are every minute. They spent a lot more time in the ICU than we were aware of. And so we had them write a paper about their experiences and what they had learned in the ICU, and then went through appropriate channels and had that approved as their meeting that ICU requirements. So we were able to utilize their skill set in paper writing and telling their experience in order to meet that graduation requirement. And they graduated, and there they are. I think I'll always call them the COVID class. There they are, and they were resilient, and they had a virtual graduation, and they had virtual speakers, and they had a great attitude, and made all kinds of revisions and adjustments to their schedules, and they graduated, and now they're taking care of patients. And so there they are. They'll forever, at least in my eyes, be known as the COVID class, and how resilient they were. So what's the state of mind? Okay, it's like people are getting tired. We've been doing this for a couple months, and we look back and, gee whiz, we were just a couple months into this thing at this time, but you feel like it's quarantine day again, or, what is your state of mind? And I saw something the other day on a national presentation. It's become March 97th every day. And that's kind of what it felt like. So it's quarantine day again, but we were doing the best that we could. So what's going to happen? Are we going to be able to get our students into the hospital when we get into July, and we're going to have an orientation? Or, things were really uncertain. And as I've interviewed people, physicians in the hospital, and people I know across the country, and read things, I think uncertainty has been one of the big stressors for people across the country in healthcare. Uncertainty of when is a surge going to come? When are we going to need more COVID units? How many are going to die? Am I going to have PTSD? And so I think uncertainty was a big issue. And there were 4 things we really needed to consider to get students back into the classroom. But here's one thing you need to know about. When this paper came out from a collaborative group in July, we didn't know these things at this time. We were making these up ourselves as we decided how are we going to work through and get our students into a clinical learning environment. This came out in July. We were already in the process of figuring out what we were going to do if we were going to have a clinical learning environment. We had to have a capacity for clinical education. We had to have PPE. Would there be enough? We hadn't had a big surge here yet. Would there be enough? Screening and testing of students, and evaluating the clinical learning environment, and then looking a little deeper into that capacity for clinical education. These were things we needed to think about, and we were thinking about all of this. And this may be on 1 or 2 slides. This is a couple months worth of work when we think about the learning environment and how are we going to have our students in a learning environment. Our students had to meet learning objectives. I've come back to that several times. It was, as a dean, my seniors were pounding into my head, they must meet the learning objectives, and they must have the clinical experiences. Who's going to supervise them? What happens if the attendings get COVID or they're quarantined for a long time period? What would we do? What do we do? Can they see COVID patients? Can they see patients under investigation, or PUIs, as we call them. What can we do in terms of rounds? What if they do virtual rounds? What if we use an iPad? Is that compliant? Is it HIPAA compliant? What are we going to do if our students get sick? What if they're quarantined? What if they're exposed and they're quarantined? Do we bring them all in at once? Do we bring them in at some other time? 2 months later, a month later, 2 weeks later? I mean, what are we going to do? Can they see standardized patients? Our standardized patients are typically 65, 70 or older. Not all of them, but some of them. Are they going to want to come over here and be with young people? What are we going to do? How are we going to monitor our students? What about aways? Can they do aways? What if they want to go see their grandma in Indianapolis, Indiana, and they want to fly there? What are we going to do with these things? And how are our students going to report safety concerns? And what kind of documents do we need to do all this with? I hope I've conveyed what we were facing and the amount of work that was going to go into this to make sure that our students could be successful. So, when we think about reentry into the clinical setting, collaboration, I'm going to say this word multiple times. It's such an important word. Collaboration, collaboration, collaboration. And we really had collaboration at its finest. Our chairs, who we have been talking with all along, our ID team, led by Dr. Skolnick and Dr. Bafubani and Dr. Gardner, calling them, the Korean Clinic C-suite supporting us and being very supportive of the school, our deans and the AAMC, and then benchmarking from Virginia Allopathic Schools. These were the 3 schools that we collaborated with and we benchmarked with, and we started that early on. UVA, VCU, and EVMS, and we met regularly with them, and we still meet with them. In fact, we met with them just this past weekend to talk about their entry for this next year. UVA's already started their next academic year with their 3rd years, and so we talked with them this weekend about how they did that and just benchmarking. I think in anything we do in the hospital or on clerkships, it's good to benchmark and see what other people are doing. So we had to make a big decision. How are we, if we could, get our students, how are we going to get them back into the hospital? And we decided to do a 4+2 model, a little different from what we talked about earlier. That 4+2 model had 4 weeks of online. This was going to be 4 weeks of in-person clinical learning, if Korean Clinic allowed that, and then a 4+2 model where they would do 2 weeks of online learning. And those weren't going to be necessarily 6 weeks that were consecutive. In other words, a student may do 4 weeks of peds clinical, and then 4 weeks of medicine, and then maybe 2 weeks of online OB, and then 4 weeks of psychiatry. And essentially, and we can kind of smile when we talk about this now, Dr. Knight did a wonderful job of setting up this schedule. And we were trying to outguess COVID. We were thinking, if we have a surge in the wintertime, that we want to make sure that we have had most of our clinical work done, and then maybe we can get them back in the hospital. We were thinking we were going to be removed from the hospital again because COVID would be so bad here. So we were trying to outguess COVID. So this slide here, it says 5 things. This right here, this slide represents 2 months of work. We had to think about PPE and Tom Hill, materials management at Carilion. Our standard operating procedures, who was going to write them, and Dr. Harrington took the lead role on that, and it took us a while to produce those, and then we continue to update them today. And in terms of these things, PPE, how are we going to get it to the students? Are we going to have enough? Are the people taking care of patients going to have enough? Will there be enough for the students? And I mentioned our SOPs, and then boarding passes. Those of us who work at Korean Clinic know, and even here at the school, we know that you have to have boarding passes every day to get into the hospital. And those are different for students because they don't have a Chronos number like we do. And so we worked with a team in HR and IT to make sure that our students would do the same thing as what is done at Korean Clinic every day. And we checked a dashboard out and made sure that they were completing these and checking off if they were symptomatic or asymptomatic. So that was a process in and of itself. And did it work? Of course, you have to do test runs. And with quarantine and testing, we relied heavily upon our ID team to guide us on that and to guide us what do we need to do and put together a plan of where our students, whether they were third year or fourth year, would quarantine for 14 days before they could come back into the hospital and before they could come even for orientation. And then they would all have to be tested before they could enter the clinical setting. So that was a plan, and we worked with Virginia Tech on that and the health department. And so that all had to be set up. And then M3 orientation, we were able to have some of that in person. We did some of that virtually. It was interesting, some of the parts that we did virtually, the evaluations of those were down from prior years. So we're going back, well, I'll tell you, I think we're going to go back to in person this year. But this slide here represented a couple months of work, and these are people who participated in this. I won't read the list, but I want to mention the word temperament here. That was in our learning objectives, and we're dealing with a lot of people. Emotions were running high. We were unsure of what was going to happen. And, you know, some people are here, some people are at the hospital, some people are in the C-suite, some people are, you know, in various places at Virginia Tech. And we had to call people a lot, and, you know, text people, call people, and everyone's busy. And the word temperament, I do want to emphasize that word, temperament and demeanor. And I do want to give an example. One night as we were trying to prepare our students to come back into year 3, it was a Friday night. I still remember this. It was a Friday night. I was pulling into my driveway and it was 8:30, and Dr. Bafubani called me, and he was still at work, and he wanted to walk through with us in infection control, how we were going to get the students into the Korean system and tested. And then if they had questions after they came into the hospital, who would they call, and, you know, the COVID hotline and those kind of things. And I remember, you know, it's 8:30 at night, and surely he's tired or he's had a long day, and he was so nice. And I just emphasize the word temperament because it meant a lot as we worked together in teams and collaborative efforts, that people were able to maintain their cool and be helpful, because that meant a lot that we were able to all work together. So what's the state of mind? Well, at this point, we're really feeling better because we think we're going to get our students back in the hospital. And this is my favorite quote, Henry David Thoreau. It works well. I'm also a psychiatrist, so it works well for me in my clinical practice. You can read it. I think it gives people hope, and it offers hope when maybe people don't have much, but it's really how we see things. And it's a beautiful quote, and I've thought of it often in the past year. So for M3 orientation, we did do some of that virtual, as I mentioned. Some was in person. Our M4 students were supportive and helped us out with our M3s. We were able to hold an ultrasound procedures workshop at the SIM Center with PPE, appropriate PPE. And our students didn't get to meet their clerkship director. We usually have a luncheon with about 80 people in the room. We weren't able to do that. We canceled some activities. So they went into the hospital with no hospital tour and having never met their first clerkship director, which was a little uneasy for them. For our M4s, there were, this was occurring on the national level, There were not going to be any away in-person electives unless the elective here did not lead to a potential residency program. So for us, those were the students who were in vascular surgery or pathology or radiology or orthopedics would be another example. We don't have those residencies here. So our students who were going into those programs were allowed to do one away, and this was recommended on a national level by the national experts, AAMC and others, and it was recommended that they could do one away. And so it's kind of the honor system, right? That all schools are abiding by the rules, because students really go away to try to see if they like the place, impress the faculty there, impress the residents, and then maybe it's a rule out. Maybe they realize they don't like it. So it goes, it's bi-directional. But our students were allowed to do one away elective in some particular fields, as I've mentioned. That also meant things for us here at home. That meant that more of our M4s were going to be here doing electives. That meant a lot. That meant budgetary issues, right? I mean, that meant a lot of things to us. So it also meant that we got to see them more, which was nice. But there were the only ones that were allowed to go away were the ones that I had mentioned. So the effects on the learning environment. We did have earlier on in this academic year some anecdotal reports of students not getting to participate as much as M3s because there would be an M4 on the service, and this would be an example. A student who had to make up, say, 2 weeks of PEDS, or had to make up 2 weeks of whatever rotation, maybe would get first shot at doing something as opposed to the M3. And we didn't hear this often, but we did hear that, and we have been aware of that, and didn't hear it much, but we wanted everyone to have a good experience. The learning environment has to be equitable to all involved, has to be equitable. And we didn't hear this much, but we're definitely aware of it and watch for any concerns about that. So this is what we've been waiting for. If we have any Korean clinic physicians on the phone, they know that we were going to have a surge, we thought, according to the national models, in April, and then it was going to be May, and it got pushed back. And, August, September, when the Tech and Radford students came back, that's when our numbers of of positive tests really started to go up. So we started to see an uptick here, especially in September. And so we started to have, more concern here about COVID, and keep that in mind, because something else is coming later. And so we really began to know that at this point, our students are going back into the hospital, and they're in the hospital, and we're in a long-term crisis at this point. This is no longer an acute crisis. This is a long-term crisis. And so I attended a national conference for a couple hours virtually a couple weeks ago. And Pam Scagliarano, COO at Yale, presented this topic and had this in her slide set. And it really struck me, because we think about leadership in a long-term crisis. So you have to have a structure, and we had a structure at this point. And you have to make decisions even rapidly at times, but you want to try to have some evidence-based decision making. And we did by this time, flexibility and a structure. And, sometimes you have to fill the gaps in. If you don't have evidence-based information, you have to fill the gaps in. And empower individuals and teams to generate ideas and action, and listen. Listen to what people are saying, respect what they're saying, be open-minded, and realize that maybe even your own assumptions about things are incorrect, but listen to those around us and see what they say. Express empathy. And we found ourselves doing this with the students. Every call, I can say every call that we had with our COVID response task force, we at some point on that call said to our students that we realize that this is stressful, and we want you to know that we get that, and we appreciate your resilience and your understanding, and we would express that to the students and let them know that we were concerned. And then you have to be present. You have to be present and ready to make decisions. So moving forward through early December, this is where we were in our clinical learning environment. There was no participation at all in the care of COVID-19 patients, and that continues even now, or PUIs. Until November, we did decide that on PEDS, we felt like our clinical learning environment was being compromised. There were so many PUIs on that service. Think about it, a PEDS patient. They're admitted, they have diarrhea, respiratory symptoms. I mean, they all look like a COVID patient. And so we did allow our students with full PPE, the proper PPE, just like faculty was wearing, to participate in the care of PUIs, patients under investigation. And if those patients then were deemed not to have COVID, we allowed our students, were deemed to have COVID, we allowed our students to still participate in care, but they couldn't enter the room, but they could certainly attend walking rounds. No participation in our NICU until November 2020. As our COVID numbers went up, we had a change of teaching attendings on IM because the hospital began to have more of a need for COVID beds, COVID rooms, COVID ICUs. And so what was 8 South, a normal teaching service for us, became a COVID unit. And so our students, we had to then include our hospitalists as teaching attendings. And I'm just so pleased to say and heartwarmed to say that we asked for a couple to help out. 15 volunteered. We had to turn folks down who wanted to help out. So kudos to the hospitalists who don't normally teach our students, but they really rose to the occasion and have done a super job for us. And our students were beginning to be exposed, and many have been exposed, and they were utilizing the Korean Clinic COVID-19 hotline, which, by the way, operated efficiently. They would get back with our students within an hour or two. So that worked very well. I'm going to show this slide quickly. Elvira Bierbeck put this in here, and I almost took this out. I leave it on my own picture, and hopefully you focus on Adrian, for one reason. And that is, last week, at night I was watching news, and 2 newscasts came on, and I was really stricken by something that they said. And that was, if you're a physician, you need to model for other people. You need to tell your patients that you received the vaccine. You need to inform people that you've had the vaccine, so that hopefully if they trust you, you can convince others that the vaccine is okay. Every patient I see in my clinic, every person, whether virtually or in person, I ask them, do they have the vaccine yet if they're over 65? And I emphasize to them the importance, and I answer any questions that they have. So I feel strongly about that we have to be in healthcare, we have to model and make others aware of the importance of doing this to save lives and get back to some sense of normalcy, because mental health issues are also becoming an issue as well. And so anyway, that's why I have this slide in here. I want to say thank you. The other reason is I want to say thank you to our ID team and human resources. They've watched out for us to the point of including our students, and even checking as we began to run low on vaccine, checking with us to make sure that we had enough vaccine for our students, and having us query them. And so I appreciate that Dr. Skolnick and team reached out to us about that and really took care of our students. Here's what we were worried about. Here's the slide that you've been waiting on if you want to hear about a surge. Our surge came, and as you can see, it came later than the national model showed way a year ago. So here we are, and in January was when we peaked out, and so this is a mean of where we were, but this is what was coming, and you're going to see how this affected even more our clinical learning environment. But here it is, and we had waited for this, and we had to make some changes. But there we are in our surge, and now our numbers are down. And had we seen this kind of numbers in October, we would have said, wow, that's really high. But now they've plateaued out, and that's still an issue for us. We'd like to see them come down in the hospital, but they're plateauing out. So we all still have work to do, mask and whatnot. We have work left to do. But in January, we had to make more changes. Our 8th and 9th floors then became COVID. And as our students return, we actually didn't have enough space for some of our students to take the internal medicine clerkship. So we had to switch students out of that onto more online work. And then we will have them take IM this spring, but we had to make more changes because we didn't have a clinical learning environment. That platform, it didn't look as bad as it did in one of those first few slides, not near as badly, I can tell you that, but we had to make some switches, and our students reacted quite well to that. They were wonderful. January 26th, we made more changes. In OBGYN, our students can, at that point, can see GYN elective surgery patients if they're greater than 21 days, what we call RPCs, recently positive COVID, and now they're out of the period of where they can infect others. Also on OB, our students for the first time this year began to be allowed to go into stage 2 labor. If the patients were greater than 21 day recently positive COVID patients, and our students were 14 days post their second vaccination. So they had to be fully vaccinated. And in internal medicine, our students can now see patients greater than 21 days RPCs, but they can't go to what we call aerosolizing generating procedures with them. So our changes have been ongoing, and they may continue to be ongoing, but things are still changing. I wanted to show you some slides so you can see our numbers. Blue is our clinical learning environment, the whole hospital, the way they look at things with organization. Blue is 2019-20 academic year. Red is 2020-21. And these are just rotations 1 to 5, because rotations 1 to 5 were normal in 2019-20, and as you recall, it was in rotation 6 when we pulled the students off. So we compared that to rotations 1 to 5 of this year. You know, not statistically significant differences. Again, much credit to our clerkship directors and our faculty and our students. Our learning environment, not a statistically significant difference. Our clinical experience, not statistically significantly different. And then our student assessment. Did they think they were assessed fairly? Did they like their web-based online learning learning materials? So no statistical significant difference is the point for all of these slides. So now we have a platform with a fire hydrant. Things are better. Our students are on track to graduate in both the M3 and the M4 class. And we're planning for I have regular year 3 and a somewhat regular year 4 next year. We know the aways are going to be limited, but we have a somewhat regular year coming up, we hope. We're planning for that. And I wanted to end with this, and I won't read it. I would like to have a 15-second moment of silence for those who have lost their lives during COVID, and allow you to read this slide and recognize the beauties of collaboration and teamwork and the work that our nurses and faculty and teachers have done. And these are my references.
Excellent. Thank you,
And I'm going to put this slide back up because it's very powerful, I think.
Absolutely.
So
Thank you.
I'm happy to take questions. And again, thank you for asking me to participate today.
Absolutely. Thank you for sharing so much about the amazing approaches that we have all taken through VTCSOM and Carillion Clinic to lead throughout this past year while doing as much as we could to avoid additional learner struggles. It's not always obvious all of the work that goes on behind the scenes. And there are many key points from your presentation that I really think that we can extrapolate to benefit all of our learning environments as we continue to navigate our current situation and beyond. So I heard collaborate with people and organizations with whom and in ways you may not have done so before. Overly communicate important messages until you feel as if your learners think you've done it too much. Remember, not everyone receives communication well in the same way, so use a variety of approaches. Embrace being creative and innovative. Whoever would have imagined that we would be doing procedures with pig feet virtually? Stick to a structure and apply evidence-based practice decision-making as much as you can, but be flexible within that structure when the structure just won't work. Empower other individuals to help and consider others' perspectives. Express empathy. We're all doing our best. Regardless of what you think or at which point you have different priorities from others, we are all trying to do our best. So I think that was expressed throughout Dr. Chris's wonderful presentation. I see lots of comments in the chat that expressing appreciation for your review of these wonderful things we've all done. So excellent presentation, wonderful. Thank you so much for a wonderful, impressive response and outcome. Thank you. Your leadership over the past year has been spectacular, and your reflections on lessons learned was filled with pearls for the future. Absolutely. Thanks, Tracy. Wonderful presentation. Great overview of a challenging year. Carillion Clinic and Virginia Tech Carillion School of Medicine are lucky to have such great leaders. Thank you so much, Tracy. Does anybody have any questions they would like to ask Dr. Chris before we close this session for the afternoon? I know we focused a lot on the students, but these techniques and strategies can really be extrapolated to all types of learners. And I know that Dr. Chris is more than happy to provide additional advice or guidance, and any of the individuals that she has mentioned are fabulous resources for strategizing for how to incorporate this within different learning environments as well.